then it is not only the LV ejection fraction that matters, but also the right ventricular ejection fraction, because it's a global disease. And if you look at it, RVEF and outcomes in heart failure, RVEF more than 35%, outcomes are better. RVEF less than 25%, outcomes are global LV strain, E by E prime, but we do the same parameters also on the right side, and that'll give you a holistic view of what's going on. RV dilatation and outcomes. If there's no RV enlargement, the outcomes are much better in DCMP. Among patients with an idiopathic dilated non-ischemic cardiomyopathy and left ventricular dysfunction, survival was much lower in those who had right ventricular enlargement. So you see, you have in your hands, with your clinical sense, you have in your hands echocardiogram transducer, and you can really make good use of it for taking this patient forward on pharmacological therapy or hospitalization. Tricuspid regurgitation gives you a very important parameter. It gives you pulmonary artery pressure. TR and outcomes in heart failure, those who have TR absent obviously fare better than those who have tricuspid grossly present. Pulmonary pressures and deaths, as I was saying, all patients underwent right heart catheterization in this study, but for a 5 millimeter mercury increase in baseline MPA, mortality rates increase. So that's how, and you can find this out from echocardiogram as well. So this is important. This is your mean pulmonary artery pressure, and this is your pulmonary capillary wedge pressure. All these, both these parameters, you can judge. The PCP you can judge from the E to E prime ratios, and the PA pressures you can judge with the use of tricuspid regurgitation jet. So each parameter that you get, both by looking at the echocardiogram as well as taking it from the Doppler echocardiogram, the hemodynamic parameters both help you a lot. So please don't forget that this is a hemodynamic instability in heart failure with reduced ejection fraction. And at the bedside, you can get almost everything by the use of Doppler echocardiography, which should be done in a nicely calibrated manner. Global longitudinal strain to predict mortality in patients with acute heart failure. Of course, life has now moved forward. Just like somebody asked me, why did you not give dapagliflozin in this patient? Why did you give only ERNI? Well, that's how it is. It is the march of science. But what I mean to say is that ejection fraction is not lost. Ejection fraction still continues to be a very important parameter. And along with that, we are using global longitudinal strain. Also, you remember, we are using global longitudinal strain in aortic stenosis patients, for example. Those who say that they are asymptomatic, their heart functions are, ejection fraction is fine. If the GLS is minus 16 or minus 15, you know that they have ischemia. So this is a study of 4,172 consecutive patients. Mean LVF was 40%, mean GLS was 10%, and they were categorized into 3 groups. And we realized that the all-cause mortality log rank was, well, you can very clearly see that with mildly decreased ejection fraction, if the GLS is also decreased, then you have a higher mortality. So it's another parameter which is giving you a lot of information into what is happening into the patient's hemodynamics. If you look at GLS and all-cause mortality, you have heart failure with preserved ejection fraction, MREF, and heart failure with reduced ejection fraction. Those who have lower curves of global longitudinal strain, they will have much worse prognosis. So that's how you can prognosticate. In multivariable analysis, with each 1% increase in GLS, GLS, there was associated 5% decreased risk of mortality. So you see, again, it comes to a very important point. How do you use them? What is your experience in using them? And it needs considerable considerable experience. But once you are there, then of course you will be able to make very good use of PA pressures, LVEDP, ejection fraction, global longitudinal strain, and reverse remodeling. You will be the master of all these things and be able to say, well, who needs it and who doesn't need it. So, ladies and gentlemen, there is a progressive increase in the Indian heart failure population, which is unique and different from its global counterparts. That is very clear, that the average age there is 73, our average age is 53, when majority of patients of heart failure are presenting to us. Echocardiography plays a key role in patients with heart failure for diagnosis, firstly, for treatment planning, which I've gone into great details of, and monitoring and prognostication. After all, the patients and patient attendants will ask you that, look, the patient has just got 20% ejection fraction. What more can you do? And then you can say, well, there is LBBB also, and the ejection fraction so and so. We'll give the maximum drugs and maybe we'll require CRTD in such. It also helps, echocardiography also helps assessing cardiac structure and function, which allows a comprehensive evaluation of all the patient status for better decision making. And that is the key, that with clinical judgment, good biochemical evaluation with ST2, NT-proBNP, and other parameters, echocardiography in its totality can give you a correct, comprehensive evaluation of the patient status. And newer methods of strain imaging, which are strain-based imaging, will also further add to eco-armamentarium and add to a better assessment of these patients. So prevent and protect is better than repent and repair. And at Medanta, we have one team, one goal, and we say every life is priceless. Thank you very much.